we do want this presentation, because I think it is one of the important things to talk about, which is sort of stigma that surrounds individuals with substance use disorders, and sort of the power of language, as it pertains to that stigma, whether by promoting it or ideally by combating it. No disclosures currently or in the past to make as we begin. We're going to appreciate that substance use disorders remain some of the most stigmatized illnesses. We'll learn how stigma can actually be a barrier to recovery. We'll learn to recognize stigmatizing language and really want to focus on what we all can do to combat stigma. I want to start with this idea that we often talk about in our seminar, but I think in many ways it's central to this discussion of stigma, right? Which is that substance use disorders are chronic diseases, in many ways similar to things like hypertension, diabetes, or asthma, right? And we've known this for a long time. This was a classic study that came out in 2000, was published in the Journal of American Medical Association. And what the authors out of University of Pennsylvania did is that they compared many of our substance use disorders to quote unquote medical chronic illnesses, such as non-insulin dependent diabetes, hypertension, as well as asthma. And what they found is that compared to these medical illnesses, the genetic impact, the heritability, in other words, how much of the contribution comes from the genes versus how much of the contribution comes from the environment, was not significantly different in all of these cases, whether it be diabetes, hypertension, asthma, or opioid use disorder, or alcohol use disorder, or cocaine use disorder. Roughly half the contribution comes from the genes, and the other half seems to come from the environment. No differences. Similarly, rates of medication adherence and relapse rates were also similar, right? And therefore, the authors really made a point that, we know that substance use disorders are chronic diseases, and therefore we must provide chronic treatments. If we just provide an acute treatment to a chronic illness and expect it to succeed, well, it's not really going to work, right? Like all chronic diseases, we need to provide chronic ongoing treatment because those are the ones that tend to be most effective, right? And yet we don't view it that way. This is sort of a slide I included because I think it's an interesting one, because we in the medical world often don't look at it this way. So this is kind of a busy slide, so I'll walk you through it. So say on the left is hypertension treatment. So say we're working with a patient, comes in to see us and their blood pressure is elevated at 160/95. We start them on treatment. Say we put them on lisinopril, and within a few weeks, the blood pressure goes down. So we compare point A and point B and say, see, the treatment is working. Your blood pressure was high. Now that you're on treatment, your blood pressure has gone down. Maybe 6 months, 8 months later, the person stops taking the medication and their blood pressure goes back up, right? Which is this last blue bar in that graph. And again, when we talk to the patient, we say, this is proof that the medication was working. When you were on it, your blood pressure was down. Now that you're off it, your blood pressure has gone up. You must go back on the medication. By contrast, that's not how we often look at substance use disorders, addictions treatment. We often talk to our patients as per the graph on the right. So the bar on the left there is that, say a patient comes to you, they're using, heroin 25, 26 days out of the month. You start them on buprenorphine and their use comes down to maybe 5 days out of the month, right? Maybe after 6 months, 8 months, they stop taking the buprenorphine and their use of that illicit opioid goes back up. And the way we often talk to our patients is that the medication did nothing. You were using heroin before and you're using heroin now. And we completely ignored what happened while the patient was on the medication. And, and I think I would posit that a lot of that difference is driven by stigma. And in fact, the stigma seems to drive a lot of things, right? Because substance use disorders remain the only conditions that I can think of in which patients are often expected to improve their conditions before being accepted into treatment. Or non-compliance or lapse are grounds for dismissal. Would we ever discharge a patient out of treatment, if their blood sugar went up or if they stopped taking their medication? Withholding known life-saving treatment is considered. Known life-saving treatment, i.e. methadone and buprenorphine, are withheld or rationed. Active disease is considered to be a crime problem. Patients are expected to discontinue non-effective treatment, right? We'll only treat you for 6 months, etc. And often there is limited or no insurance coverage for effective treatment. And I think, again, it seems like a lot of this is driven by stigma, as we'll talk about. Stigma indeed is prevalent, right? Going forward, so substance use disorders remain, according to the literature, likely the top most stigmatized condition across different societies. And even compared to other mental illnesses, which themselves are so highly stigmatized, people have even more stigmatizing and discriminatory views towards those with addiction disorders, substance use disorders. This is a study from 2014. It was a large survey, right? What they found is, so you can see that 62% of respondents said they would work with someone who had a mental illness, but only 22% said they would actually work with someone who had a substance use disorder, right? 25% said that employers should be able to deny employment to those affected by a mental illness such as schizophrenia or bipolar disorder, etc. But again, almost 2/3, 64% believe that employers should be able to deny employment to those individuals who are affected by addiction, right? Similarly, almost half, 43%, actually opposed giving individuals with substance use disorders the same health insurance benefits that are granted to otherwise healthy individuals. Just let that sink in for a minute, right? Like almost half of people think that individuals with substance use disorders should actually not have the same health insurance benefits. 90% were unwilling to have a person with a substance use disorder marry into their family. And over half thought landlords should actually be able to deny housing to a person with a substance use disorder. So imagine, right? I think it's a more point for reflection what our lives would be if we were faced with this type of attitudes, this type of belief systems on a day-to-day basis in our daily interactions. Just as concerningly, we as healthcare providers are not immune from stigma. It's been shown that healthcare professionals often perceive things like violence, manipulation, and poor motivation as factors that impede healthcare delivery to patients with substance use disorders. This has been studied a couple of times with various medical residents. Most recently in 2017, there was a study done that showed that psychiatry resident attitudes towards patients with substance use disorders actually worsened, became more stigmatized as they went through the course of their training. And I think a lot of factors play into this, right? There is overall a lack of training in our professional curriculums about how to treat substance use disorders, lack of education and lack of support. I also think a lot about this, right? That at least when I think about our psychiatry residents, which is what this study by Avery refers to, as they go through their training, very often the patients they see with substance use disorders are the ones who are not doing well, who are maybe hospitalized with end-stage liver disease related to alcohol use, or the ones who are routinely coming into the emergency room as a result of methamphetamine intoxication. What there is often no exposure to are the patients who are doing well, are those individuals who are in recovery, who are trying to get their lives kind of in control, right? Or are living their lives with all the challenges and triumphs of it. There is often no exposure to it. There is also often this hidden curriculum that I can certainly say I encountered when I was a resident, right? Kind of words like, oh, that this person is just an addict, or this person is just a frequent flyer as they come into the emergency department. And those attitudes often become ingrained as we go through our training. So we really need to think about how do we allow a trainee to see all aspects of substance use disorder, right? Including patients who are not doing well, but also including those who are doing well. It's been shown that, let's see, kind of going forward, language does matter, right? And I use this example of dirty urine or positive urine, right? Which is a common word we all are, I think, using or have used. I certainly have, calling someone's urine dirty. Studies have shown that using the word dirty urine or clean urine, for example, can be stigmatizing. So we often try to use very objective terms like urine that's positive for opioids, for example, or urine that was maybe unexpectedly positive for methamphetamine, things like that, right? So going forward, so does language actually matter? So this is actually a very interesting study that was done many years ago, but I think this does capture the power of language. So in this study, two groups of people read the same exact clinical vignette, right? They read the same story about a fictitious individual. However, one group read about a quote unquote substance abuser, while the other group read about quote unquote a person with a substance use disorder. That was the only thing that was changed in the story, was how that person was referred to: substance abuser versus person with a substance use disorder. And then those individuals were asked a series of questions. And you can see that when someone read about, a substance abuser, about 40% thought the person should be in treatment, and 2/3 thought the person actually should be punished for their substance use. But when the group read about a person with a substance use disorder, you can see how dramatically different those results were, right? Where almost 70% said the person should receive treatment, and only less than a quarter thought the person should be punished. The group that read about a person with a substance use disorder was also less likely to see the person as a social threat or say that this was the person's own fault, right? So I think just changing that word really seemed to change how people perceive an individual. So something to really keep in mind. And I think one of the things I often talk about is that as clinicians, as healthcare professionals, I think if we can cultivate an environment within our own clinics where we can respectfully just call each other out, right? Like if I use a stigmatizing word, just kind of give permission to my colleagues, my healthcare team, to say, hey, why don't you use this word instead? I think then we can really start to use language that might be more respectful and certainly less stigmatizing towards our patients. Why does stigma matter? And why does language matter? Because we know that stigma worsens outcomes. We know that when people are continuously faced with stigma, that stigma is often internalized, right? It's turned inwards. And that can lead to things like shame, guilt, low self-esteem, low self-efficacy, learned helplessness, right? Why try effect? That I'm doing all this, I'm trying really hard, but people still view me as quote unquote an addict. Why should I even try? Ultimately leading to demoralization as well as feelings of inadequacy, right? And we know that individuals with substance use disorders often perceive stigma. This study from 2006 looked exactly at that, finding that people with substance use disorders frequently thought, right, that people treated them unfairly because they knew about their substance use. Almost half felt feared by others, and almost half felt abandoned actually by their family members. So this is sort of the subjective experience, unfortunately, for many of our patients. And that ultimately matters, because what studies have shown is people with substance use disorders who perceive that high levels of stigma are actually less likely to seek help, right? So they're less likely to seek help. And if they do seek help, they're more likely to drop out of treatment due to the stigma. So they're also less likely to stay in treatment if they do seek treatment. Healthcare professionals, on the other hand, all of us, again, tend to hold people with substance use disorders in poor regard relative to other patients, again, viewing them as poorly motivated, violent, manipulative, and may actually avoid these patients or shorten visits, leading to suboptimal care. So it sort of sets up a perfect storm where there's this interaction between self-stigma that's been internalized by many of our patients and the stigma held by healthcare professionals, ultimately leading to worsened outcomes, right? And outcomes, in fact, are worsened. So here for this slide, I started by listing the recovery components as cited by SAMHSA, right? So according to SAMHSA, according to the American Psychiatric Association, many other professional organizations, hope for the future is the cornerstone of recovery, right? When someone is in recovery, hopefully that hope is reinvigorated. And we know that recovery is associated with improved outcomes in all of these components: health, both physical as well as psychological. We know that recovery is associated with improved physical health, improved psychological health. Home, having a stable place to live, right? And it's a bidirectional relationship. A sense of purpose, right? A sense of community, feeling like you belong, you have a meaningful role to play within your community, whatever it might be. These are all components of recovery. And what studies seem to indicate is when people are faced with stigma, right? People who perceive high levels of stigma tend to have worse outcomes in all of these components of recovery, including, again, less likely to seek treatment, less likely to stay in treatment, worse mental health, worse physical health, decreased employment, unstable housing, breakdown of social support systems, and worse SUD outcomes. So in other words, stigma is a direct and very clear barrier to recovery in individuals with substance use disorders. And another thing, though, beyond the scope of this presentation that I would like to point out is that for many of our patients, there are multiple layers of stigma, right, that they're encountering, maybe based upon their background, maybe because of their history of trauma, right? Childhood circumstances. Like there are so many layers of trauma and stigma that have been piled on. So I think doubly critical for all of us who are interacting with our clients, our patients, to create an accepting, respectful, and non-stigmatizing environment. So to that end, what can I do? Is there anything we can do? Certainly there are, right? And these might sound like common sense things, but I think this is a good place to start. Respect is critical. Treating people affected by addiction with respect, and really seeing them as people first, right? When I think about my patients, at our clinic at UNM, sure, they have substance use disorders. That's why they're seeing me, but they also have other things, right? They're parents, they're holding down jobs. Maybe they're taking care of their elderly parents. They will often overcome amazing trauma that actually, when I understand that, when I can appreciate that, kind of fills me and helps me appreciate just the sense of resilience that they may have demonstrated. Learn about the science of mental health conditions and substance use disorders. I think when we really start learning the science of it, then we can start combating some of these discrepancies that exist and some of these, myths that exist, and correct others, right, who have misconceptions about substance use disorders and mental illnesses. Support resources. Resources matter, right? So including resources like housing assistance, supported employment. All of those things tend to improve outcomes, but often those resources are hard to access. Educate. Appreciate that most people with substance use disorders do make recovery with treatment and lead productive lives. And if you're in that position, if you have lived experience, being a personal witness, right, putting a face and voice on recovery, like many of our peer support specialists do on a daily basis, kind of living that, can be hugely powerful, right? Far more powerful than what I can present. In fact, one of the cool things we got to do this year for our fellows in addiction medicine is that when we did their kind of educational lecture on stigma, we actually, brought in people with lived experience to share that, because again, that's essential, I think, for education and for hopefully training the next generation of providers who are going to be more respectful and less stigmatized and hold less stigmatized views. Check our language, check our terminology, right? And if we all do that, then we can start moving towards this idea where, hello, I'm not my addiction, right? That our patients, our clients are much more than their substance use disorders. Always be an advocate for your patients, right? Which is, I think, just an important part of being clinicians, being providers, creating and accepting patient-centered environments, work with tribal, state, national leadership to enact policies that will ultimately benefit communities, including funding for treatment, drug take-back programs, education efforts, right? Youth engagement. And finally, I've included just some words here, kind of commonly encountered stigmatizing language, and maybe some other words that we may want to use as opposed to that. And then finally, ATTC does have an anti-stigma toolkit. Sometimes this link has a funny way of vanishing, but it does appear within their website. So if that happens, just reach out to me and I can help you access that. But with that, I will stop here.